Well, good morning, everyone. Welcome. Thanks for coming out early and joining us. We are in room 404, a conference room adjacent to our administrative offices. We're all spread out, so I'm going to be able to take my mask off and talk here. In case you don't know, if you haven't been involved in a public meeting lately, the interpretation of the Open Meetings Act by our Attorney General's office due to virtual meetings require roll call votes for everything. For expedience sake, I'm going to forego the roll call to open the meeting, but we're taking that as we see it on the screen. And we do have one action item, so we'll take roll. I'll be calling roll for everyone. So you'll have to unmute because we actually need an audio response for that as we go through that session. So with that being said, I'll go ahead and start the meeting, call the meeting to order. Item number 2 on our list is approval of the minutes of March 13th and April 27th. Is there a motion to approve? I can take a show of hands for this. Motion by member Schultz, second by member Berry. Any comments, questions, additions, or corrections to our minutes? If none, we'll have a roll call vote for approval. Thank you. Ms. Morlock is in the back of our room, and she will be taking a roll call.
Elizabeth Robb.
Approve.
Sonia Reese.
She's not down on you.
Ms. Sonia Reese.
Yeah, there she is.
Yes.
Yes. Thank you.
Okay. Mr. Mark Jontry.
Yes.
Diane Schultz.
Approve.
Kevin McCarthy.
Aye.
Joni Painter.
Yes.
Tom Barr.
Yes.
Karen Zangerly.
Yes.
Stephanie Barrett.
Yes.
Kristen Adams.
Yes.
Eric. Is it Tom?
Yes.
Tommy, yes.
Tommy, sorry. Thank you. Rebecca Foley.
Aye.
Susan Schaefer.
Yes.
David Taylor.
Yes.
And if there's someone sitting in for someone, Chris, do they vote or no?
No.
No, that's okay. John McIntyre.
Yes. The motion carries unanimously, and we do have a quorum, so we'll go ahead and proceed with our meeting at that point in time. At this point in time, I'd like to welcome Mr. David Taylor, Executive Director of United Way, McLean County, for joining us. United Way has been very helpful and involved with all of our initiatives and also helpful during this COVID crisis. So, David, thank you. Welcome. Glad you could join us today. Neil, thank you for joining us. I think you're subbing in. And anyone else we have on here, welcome. And we'll go ahead and get started with the meeting from there. I'm on item 5 already, items to be presented for information. I'm going to turn this over to Ms. Malott, and we're going to have a number of presentations to kind of catch up. If you all have your packets in front of you, that would be good to refer to. Okay, thank you. On.
Okay. To provide a little bit of an update on the Triage Center.
Oh, you're not muted. There we go.
Okay. And this is why we keep IT around.
Wait a
So
minute, who's muting who is?
No, she's good.
She's
yeah,
good?
because the mics can just me up.
Okay.
I screwed it up.
Okay.
Starting on page 11 are some pie charts to update on Triage Center and clients that have come in. Since we opened, we did recently extend our hours to 7:30 a.m. To 3 a.m. 7 days per week, 365 days per year. And while I certainly, on one hand, wish that we didn't have individuals who needed to come through I am also really glad that we serve as a resource for the folks who do and who are struggling. So we had an individual who did come in on Labor Day, and it was a nice thing to be able to get a response from staff who were there working that day, knowing that we were open on a holiday when a lot of other resources aren't always available. So in looking, what the first chart is for referral source, and so far about 40% of our referral sources are coming from law enforcement drop-off. As a quick reminder, we continue to serve as a diversion option for law enforcement when they encounter individuals with behavioral health concern or crisis. And it may be that they are called out because of that, or that they are interacting with that individual for a low-level offense. And in their interaction, encounter or realize that there may be behavioral health concern. And we serve as an option either to avoid the justice system or to avoid emergency departments. So we've had about 40% come from law enforcement. 20% have come as referrals from friends or family. We have 13 who have brought themselves and come on their own and identified themselves as not having heard about it from someone else. And similarly, 13% from mobile crisis, and then 7% from Chestnut, and 7% from another entity that we're just sort of broadly capturing as other. To provide a few examples that fit into that referral source, or sort of where we're fitting in this, we have one individual in the community who has interacted with a number of service providers and crisis resources, and came to triage one day, brought by law enforcement. They knew that that individual really did not need the hospital or a higher level of care in that moment, did not want to have direct interaction with their particular service provider in that moment, so they brought them to triage. For an individual that law enforcement would have generally spent potentially hours with, they were able to bring them to triage, and in that person's particular case, law enforcement was in and out in 2 minutes. So it's a clear example of how it saved officer time. And the individual I referenced on Labor Day was actually someone who had previously presented to the ER and had been assessed by mobile crisis as part of their safety plan for ongoing care. Mobile crisis had included the triage center as part of their safety plan in case they needed follow-up at some point, or felt the way they did again that took them to the ER in the first place. And so those are just a couple examples of people who have come in and how part of that referral system is working. Looking through, I identified which law enforcement agencies have been bringing more than others. I anticipate that some of this will change over time. It is important to note that, one, we opened right at the start of COVID and shelter in place. And so that certainly impacted the number of people that have come through, but it also impacted the roll call briefings that we were able to do with law enforcement. So prior to shelter in place, we had only made it through roll call briefings at Bloomington Police Department and had not made it through many of Normal's regular patrol shifts. We had made it to their supervisor meeting. And so I think that clearly plays a part here. So I don't want to give the impression that Normal isn't utilizing it, simply that timing and in-person meetings to be able to do those roll call briefings played a part. One of the things that we have wanted to track is how long law enforcement spends when they do drop somebody off. It is one of the pieces that, as I've looked at other jurisdictions that have done this type of diversion model, has not been really either accurately or thoroughly captured on what that impact to a community is. And so we wanted to make sure that we really are capturing that amount of time. And so we are not only identifying and keeping track of which law enforcement agency, but also how long that officer is there from start to finish. And so you'll see that the average amount of time is 5 minutes if we exclude one outlier. And that one outlier was a 45-minute case of somebody who did not really want to be at triage. So it took a much longer conversation with law enforcement present to determine whether that person was going to stay or whether law enforcement needed to make a different choice. And again, because we are a voluntary site, so all services are voluntary. If somebody doesn't want a service, they don't have to be there. They have the right to leave or refuse an assessment or further care. So that's why I identified we have an average that includes that one outlier, and we have an average that excludes it. And then we're also keeping track of where the person goes once they leave us. We have said from the beginning that we will work to get people to wherever they may need to be, even if we are not the right location. And we have had a few of those situations where either people have come in on their own or been brought by law enforcement where they did need a higher level of care and they did need to be hospitalized. And much like mobile crisis or the CRU, we fill out the petition. If we have started the assessment, we send our started assessment with them and we get them to form of treatment that they need. And other times they receive their assessment, they're in the moment intervention, linkage to ongoing resources and referrals, and leave on their own when they feel comfortable. And so that's shown in the chart at the bottom of page 12. And then we're also keeping track of how long people are spending there. The majority, and I realize that my percentages didn't print in this, but 46% of people spend 2 to 4 hours. That has been the largest amount of time or the largest percentage of people for the amount of time that they're spending. And so we're recognizing that that's it. And so far, I can identify that people, when they come in, have not had to wait more than 15 minutes to be seen. But part of that time and that 15 minutes is also them filling out their initial intake paperwork. And so some people have needed some assistance with that, which is where our peer comes in. The peer often helps with that part of the process if somebody needs help filling out that initial intake form. So we're looking at truly from the moment they walk in the door to the moment they leave. We are, now that we have expanded our hours, we are beginning to advertise and have sent final marketing materials to be printed. So we anticipate that the number of individuals coming through triage will begin to pick up now that we're doing that. I had wanted to wait until we had what would be a permanent or close to permanent schedule and hours so that we didn't send mixed messages to the community. Are there any questions about triage?
Just a quick
Tricia.
one.
Go ahead.
How many people does
Stephanie,
this
go ahead.
represent? How many people have been served by triage?
So I did not bring the exact number. I believe it's right around 15. It has picked up in the past month or two. It was certainly slow in probably through June, like through the end of June. And the positive that I can identify in that is I think it was really representative of people truly sheltering in place. And so while we wanted to open as planned to be a resource, knowing that that could be a difficult time. If I take the downside of not having many people come through initially, the positive of that is that they were sheltering in place. So.
Tricia, this is Tom. Stephanie beat me to one of my questions, which was how many people were served. Are you tracking also how many people or duplicate contacts of those 15, how many may have come back for multiple times at different points since the triage center has been opened?
Yes. So the 15 are 15 unique individuals. We actually keep track of each interaction and by name. And so I can identify who has returned more than once. We do have, I think, 2 people who have come in on more than one occasion. And one of them has even just stopped in on occasion to say hi because they were happy with the services. And so it's just, and they're not, that interaction is not counted in our tracking. I just know that from discussion from staff, so.
Thank you.
Anyone else?
Trisha
Yes, sir.
Kevin McCarthy. Thanks for this update. I'm curious, is this cumulative data from the whole time the center's been open? And are you planning to do time period based reporting, or can you talk to us about what we can expect about reporting on the center going forward?
Yeah, so this is representative of cumulative data through the beginning of September. So this is from opening, which was March 16th, to the end of August, prior to me putting this information for the packet together. Ongoing, my intent would be to put it together on a quarterly basis, since BHCC meets quarterly. I can also break it out to show cumulative as well. I mean, so I can actually pretty easily do it both ways and consistently show current quarter and cumulative.
That would be fantastic. Thank you.
I have
Sorry.
okay. I just had a kind of a heads up thing for you, Trish, in that Safe Harbor, which is primarily people with behavioral health issues, they have cut their space in half so that they can maintain distancing. And so that's going to put a lot more people onto the streets, and you may find more coming in. And of course, during the winter months, I expect you'll be fairly busy. But that is going to be a big change, and we don't have any solid answers to where we're going to put those folks. So just want to let you know.
Okay, thank you.
Karen, let me ask, have they had any occasions where isolation is going to be needed or quarantine where we could involve the emergency management agency for sites that we have?
Yes, we are part of the emergency management team working on this. And so right now we're meeting weekly. We were able to, during the time period, we've been able to put people into quarantine or isolation, but there was a lot of federal money that allowed us to put them into hotels, and that money is no longer available. So we have new decisions to make about people who've been exposed and people who need to be in quarantine. So it's going to be a messy fall, I think.
For those of you who don't know, since the governor's declaration of emergency clear back in, I think it was 1st of March, emergency management agency has had places established and agreements, MOU agreements with different places. They haven't been disclosed for privacy reasons, but and we've been very fortunate early on when we didn't have many cases. Positive rates was good, but we're projecting that we're going to be using those now. So where you still have everything in place, and that's good.
And I'm happy to say that with the homeless, I know I'm getting off track, so I'll be quiet, but we were very proud that none of the homeless came down with COVID-19.
Great,
That's good news. Anyone else have a question? Some of you.
yeah, just a quick question. Just a quick question for Tricia. It's Kristen Adams. Is there a benchmark or a data point of how many clients you do want to see on a monthly or quarterly basis of what you're shooting for?
I haven't specifically established that necessarily, in part because it's a little bit hard to predict or know how many may come through the door. I mean, prior to opening, we did research and we looked at what PATHS numbers had been historically, what mobile crisis had been historically. We've had conversations with both hospitals to know what they're reporting from their ER usage and how many they are seeing that don't end up admitted, that don't need to be there. But it's still hard to know out of all of that, how many people are then truly going to walk through the door. So as much as that person may present to the ER or may call mobile crisis or PATH and be given the resource for triage, there's still the level of choice and individual determination in terms of whether they actually come to triage and walk through our door. So there's some of it that I think is hard to predict. My initial goal is I would be happy if 1 to 2 people came every day. Like that's my initial starting point of where I will feel like, okay, we are truly starting to reach more people. We can certainly handle much more than that. But in my mind, that's a good starting point to move us forward.
Thank you. And then the only thing that I would ask is, as the marketing materials become more available is, for instance, we'll take them at Country. So you kind of disperse those with local HR departments. I think, for instance, we're seeing an increase of challenging times for our employees. I just think it'd be helpful to get that equipped to HR professionals.
Absolutely, we can do that.
Thank you.
Yeah, we ended up doing a few different materials. I mean, so we do have some sort of short and sweet posters that we have that we can put throughout the community, but we also created brochures that certainly go into a little bit more depth, but also a 5x7 front and back card, which is sort of the hybrid of the poster and the brochure. So it is a little bit more information than that poster, but it's small enough that somebody could easily hand it. If you're, female or male and you have a bag or a purse or something, you can quickly stick it in. It's sturdy enough to not get bent up and beat up, but connects people and explains a little bit about us. And we did that so that some of those are a lot easier to hand out, whether it be from an HR department or from a primary care office or another service agency.
That's great. Thank you so much.
Thanks, Kristen. Anyone else?
One final question, if I may. This is Tom Barr. Along with what you've shared with us in terms of the information, is there, without going into a ton of detail, additional data points or information you're wanting to track and or ultimately outcomes that you're hoping to achieve that you're starting to establish as you're tracking and getting more data?
Yeah.
I recognize with COVID, it's been a challenging time, but I was just curious.
Yeah, we're actually probably tracking almost 30 different items from when they come in, ranging from have they ever received a diagnosis before, have they been elsewhere for help in the past, again, where are we discharging to, are they a return individual, as well as how they scored on the Columbia that we're doing with them. So we're looking at a lot of that information. One of the other pieces that we are going to look at is what was their justice contact like 30 days prior to coming in, especially for those brought by law enforcement, to what is their justice contact for 60 days after. And that arose, a piece of that was one of my thoughts for tracking data, but then the 60 days post, that number came as a result of a conversation I had with one of the chiefs. And while I had initially thought 30 days, in part because I mentally live a little bit more in the medical world, where 30 days is often the benchmark for staying out of the hospital or not having significant change. That particular chief suggested 60 days. So we are looking at 30 days prior for justice and 60 days post for justice contact. So I also anticipate moving forward, there will be some other data that proves to be more significant going forward. You know, had I reported on how many people had received a mental health diagnosis prior to coming into triage, I want to say it was all of them, but maybe one. You know, and so there wasn't as much variation in that. And I can certainly, in future meetings, report on additional data because we're actually tracking quite a bit.
And are you able to track sort of the disposition in terms of where they go from there and whether or not, for example, you need to refer to the hospital or refer to Chestnut or the referrals to you are appropriate and you're able to resolve the issue without involving a more intensive program?
Yeah, that's actually represented in that bottom chart on page 12. So we have identified whether people are returning home or to a hospital or to another location. So far, we have had to send a couple of individuals to the hospital. One of them was their specific request. We also agreed that it was clinically appropriate, but they also requested and identified that's where they thought they should be. We have not had anyone go to the CRU yet, though we have had a couple of individuals that from behavioral health clinical standpoint were appropriate, but due to medical reasons did not meet all of the CRU's criteria. And so we are tracking where they ultimately go once they leave us. So if they're captured in the even the home shelter or other, those are individuals who have received the level of care that they needed in that moment. Again, had we had a successful referral to the CRU, it would be captured as Chestnut on here as a different level of care.
Thank you.
Mhm.
Okay, well, we'll move on. Okay. Thank you. How about our lab pilot project?
Okay. I will try to be a little bit more concise on the FUSE discussion than I was on triage. On page 14 well, I'll back up a moment before I get into that. I want to recap, while I think everyone is familiar, FUSE stands for Frequent User System Engagement. And this is really for our individuals who most frequently interact with two of the three high-cost, high-need systems of care, be it the justice system, emergency departments, or the homeless system. We partnered with the University of Chicago to create a data matching tool that allows us to see the intersection of the data between the justice system and the homeless system. And on a monthly basis, I run a new report and then filter out those who do not have behavioral health indicators, and also sort based on total number of contacts, most recent contact with the homeless system. And so page 14 shows what the current top 25 have as their averages. So when I look at the shelter days on average, jail contacts, jail bed days, and ER visits, and the only thing I will say is the ER visits are the average based on our current FUSE participants. Since our data matching tool does not include health data, I can't have that information ahead of time. But we do have everybody who comes on or is looking to potentially be a FUSE participant sign a release of information, allowing us to contact Chestnut, CHS, and the hospitals at minimum, as well as any other service provider they may have been involved with, to determine what their crisis system interaction has been. So that particular one is based on our current FUSE participants, what their average visits have been. But you'll see that on average, though, an individual in the top 25 are having almost 120 shelter days, and that's in an 18-month period. So each month when I run it, I'm looking at the most recent 18 months. They've had 6 jail contacts on average and almost 77 jail bed days. Looking at page 15, this is information on our current Fuse participants. And so with our current Fuse participants, we have only had 1 client who has had any new contact with the justice system since becoming a Fuse participant, and they had 2 contacts, one of which was an arrest, and it was a probation violation. With regard to the shelter data, we have 2 individuals who were previously housed before they came to us, so they have also remained housed. We have 2 that we helped with the mainstream housing voucher application process who were successful in receiving a voucher, and then we assisted them in finding housing. So we have 2 that became housed since joining Fuse. And we have 1 who is on the waiting list for a voucher, but is in the process of seeking housing, even as they wait for that voucher. Because one of the other pieces that we have been able to assist with is we've helped individuals apply for unemployment. We have a couple who work odds and ends and temporary jobs that may be in the construction or roofing world where it can change. And so we have a couple who lost employment in the midst of COVID. And we helped them apply for unemployment and for the separate special COVID unemployment piece. And we're successful in them getting that. So fortunately, the 1 individual who is on the waiting list and not yet housed, just about 2 weeks ago, successfully received their COVID unemployment payment, which allows them the opportunity to actually have their own resources to seek housing and pay for rent. And they took some time and went and visited a family member, and that's actually the only reason that they have not yet found housing, because they have been gone visiting family. With regard to interaction with ER crisis, we've also only had 2 clients who have had new crisis system interaction. We had 1 client with 1 ER visit, although I will note that it was actually medical and not behavioral health. And we have 1 client who has had 5 ER visits, though at least half of those have been medical related and not behavioral health, and 1 triage visit. So all of them have had a reduction from what they were before they became involved with Fuse. The majority of them no longer interacting with any of 3 systems. And this is data that we'll continue to track. And as we have more robust data, we'll, part of what we did as we were planning this was looking at the costs of each type of service, so that we can also scale that out and identify what type of cost savings this is. We did put outreach on hold in mid-March when shelter in place occurred. And just near the end of August, resumed outreach to new participants. So COVID certainly impacted continuing to add new participants, but we have resumed outreach, and I anticipate that we'll have even more data to share in December.
Anybody have any questions?
Hi, this is Tom Barr. I've got just a couple quick questions, Tricia. How many people do you put in the Fuse right now?
We have had 5.
Okay, and this is sometimes a challenging population to engage. How many have you've tried to reach out to that have possibly declined, since this is a voluntary program? Do you have any idea? Just continued once treatment was started?
Once treatment was started?
Well, once you, either people who have declined from the start saying no, thank you, or who have gotten involved but may have decided later that they were not interested or did not follow through.
Sure. So not joining at all, I don't have that exact number. I mean, we've kept track of anyone we've done outreach to, but that's not specific data that I have kept in terms of keeping numbers on. I would, off the top of my head, I believe it's been less than 5 who we've done outreach to, and that's in the past 15 months, probably 5 or fewer that we have done outreach to that have declined. And frequently that has been because they've already been involved with another service provider in some capacity. And so they chose not to change, which is perfectly fine and understandable.
Thank you.
Most of you know, some of you might not know, just for your information, that this intersect of the visits of all of our different systems it's taken quite some time to get everyone to sign on releasing information so we can compile this. We feel like, though, it's a great benefit to our criminal justice system as well, and because and our ER system. So I'm sure it's going to continue. Our goal was to set was for 10 each year. I personally I thought maybe we would have more than that. But with COVID and other situations going on right now, I'm happy that we haven't had. But I know it's going to continue, and it's a great service. Got to thank the Bloomington Housing Authority for helping. Who else has been involved with you on that? Anyone else as far as providing services?
Oh, we work with most of the service providers.
Most providers.
I mean,
okay.
on some level. So, yeah.
Susan, you have anything to add? Okay, thank you. Shall we go on? I jumped ahead on you.
No, that's okay.
Ready for the NYU?
Yep. So our next agenda item is on the NYU Criminal Justice Lab Police Screening Tool Pilot Project update. And this is one where in several meetings you've heard my recap. Because we are moving further along in this, I actually, wanted to make sure I didn't miss anything, but I also thought maybe it would be important for you to hear from one of the lead consultants on the project, what their description sort of start to finish is. So this is one update that I am not going to put into my own words. I am actually going to read his update, and he has been, so he's a consultant with NYU, who also has worked with Arnold Ventures in the past on data-driven justice, and is very heavily involved in justice reform and changes. And so I will read his update. So I hope it adds perhaps a slightly different perspective than just my usual interpretation. So he started with identifying the need. Across the country, law enforcement agencies and jails are struggling to deal with a large population of people who are involved with the criminal justice system, in large part because of their issues with mental illness, substance abuse, or homelessness. Many of these people cycle frequently through our jails, often because they are charged with low-level offenses that are never provided with services that could address these underlying problems. After all, jails are designed to incarcerate and punish, not to respond to the social problems that often lead to crime. This means that we're spending an enormous amount of resources on this population without treating the underlying problems that drive crime and not helping these individuals have better prospects when they're released. Recognizing this fact, a growing number of law enforcement leaders are looking for alternatives to arrest, not for everyone, but for the people who may have engaged in criminal conduct largely because they are homeless, addicted to drugs or alcohol, or are experiencing mental illness. This population would likely do better if they were not incarcerated, but instead were connected with the treatment and services that could help them get back on the right path. The problem is that until now, police have had no way to identify them. So to respond to that need, the Criminal Justice Lab at New York University School of Law brought together a group of experts in mental health, substance use, and homelessness to begin designing a short questionnaire that could be used by law enforcement to figure out which people they encountered might be dealing with one of these issues. While many instruments exist that can diagnose these issues in a clinical setting, they're typically far too long and detailed for a police officer to use on the street. These experts developed a handful of questions, which now number 10, that could be quickly administered by police during an encounter, and that they hoped would flag individuals who could benefit from diversion. And I'll insert quickly here, there have been 2 phases to this project up to this point. The first phase was in Marion County, Indiana, which embodies Indianapolis. So phase 1 of the project was with, I believe, 10 officers in the field who administered the tool at that point in time to determine how long was it taking, were the questions easy to understand, both by the officer and the individual, and what was officers' perception of how people were responding to it. That went well. They identified it on average only took about 3 minutes to administer. And the tool at that point was actually longer than what it has become. It was, I believe, 14 questions and about 10 observations by the officer at its initial point. Phase 2 then included us and was last fall. And so still remained with Marion County and also included us, and was done in the booking process in the jail. So for every individual who was booked into the jail between approximately Labor Day and early December, they were at original booking given the tool by a corrections officer, and then between either my staff or some contracted clinicians or graduate students were then administered an assessment tool known as the Mini, which has been validated for diagnostic purposes. And then from that point, NYU has had psychometricians analyze the data to then get us to where we are now. So I'll get back to reading Matt's update, but that's just a little bit of in-between context before we move on to discussion of validation. The lab engaged in a 2-step validation process to test whether this first of its kind instrument could work. In 2018, we developed an app for tablet computers that was rolled out to a small group of police officers in Indianapolis. The purpose of the phase was to determine whether a short questionnaire could be administered in the field. These officers reported that individuals generally understood and responded to the questions. The instrument took less than 5 minutes to complete. The lab then proceeded to the second phase, where we tested whether this short list of questions could accurately identify individuals dealing with mental illness, substance use, and homelessness. We administered the tool to 712 individuals booked into jail in Indianapolis and in McLean County. We then administered a validated extensive diagnostic tool, the Mini, to the same 712 people. And we found that the correlations between the two were very strong. Using just 10 questions, the NYU tool was able to identify individuals dealing with mental illness, including suicidality and substance use issues, with a high degree of accuracy. The current scoring rubric would flag for officers individuals with an approximately 3.5 times greater likelihood of having one or more of these issues than those who are not flagged. The tool has now been validated to provide law enforcement officers with information they can use to make diversion decisions. It involves 10 questions pertaining to mental health, substance use, and homelessness. And we are now ready to deploy it on the ground to help officers make decisions about who to divert. The tool will provide law enforcement with guidance about which individuals should be considered for diversion. Of course, some people will be suspected of crimes, such as those that are serious and/or violent, that would make them ineligible for diversion. But for the rest, the tool will be used to help officers decide whether someone is likely to benefit from diversion to treatment and services. The lab is working with Indianapolis and McLean County to test the tool on the ground to help officers make decisions about diversion. We'll gather data to evaluate whether officers are using the instrument, whether individuals are being connected with services, and whether those diversions are working. So Right now, we are in the process of continuing to work with NYU on what phase 3 looks like. We have had discussions with the chiefs in Bloomington and Normal and the sheriff. And so it will be something that will, once the technology is worked out with all 3 entities, will begin to be rolled out in the community with officers in the field who will use the tool. The tool will then help guide them for what the appropriate resource may be. And some of those specifics have not yet been worked out because we are not at the point of identifying what the procedures will be for it. But that's where we're heading. So we anticipate that still sometime this fall, we will be able to roll out phase 3 of the pilot. Yes, Neil.
Patricia, is the goal of this particular program to see if they might need a crisis intervention immediately or after the arrest, then a referral to another program? What's the goal specifically?
Yeah, the goal is actually to divert from the justice system. So the goal is to help officers be better equipped and know that this individual may be better linked to treatment rather than enter the justice system. So it is not, it's not intended for post-arrest treatment. It is intended for pre-arrest diversion.
Anyone else? Catch your breath for a minute. Move on to your case study. You all have the NACO page 16 in front of you in the packet there about the article that came out, and Tricia will refer to it next.
Yeah.
Excuse me, sorry, it's Beth Rob. Could I go back to the,
Sure.
to this, does this little questionnaire capture any demographics as far as age, gender, race?
So the data collected in the pilot has and will continue to, but the questions on the tool do not ask for those. So in the interest of research, yes, that data has been collected and will continue to be collected in the next phase, but the tool itself does not ask for those questions.
Okay, thank you.
You. Good question. Anybody else? Okay.
Okay. So as part of our ongoing collaboration with the National Association of Counties, our continued participation in the Data-Driven Justice Project and the Stepping Up Initiative, NACO recently wrote and published a case study about our efforts relative to the intersection of behavioral health and the justice system, including the use of data. And specific attention was paid to the use of data for the FUSE program. So I won't read or recap this for you, but I wanted to share it with you. I think they did a really nice job, one, of writing it and putting the information together. But I think it's a really great representation of what has been done in the county over a number of years. And so I just wanted to make sure that all of you had the chance to see it and hopefully read it as well. So.
Well, our forum is going to take on a new aspect this time around this year. Is this our 4th year for a forum?
Yes. Yes.
And of course, like everything else, we're involved in trying to reach people. But those of you who have been on the committee know that we have a different plan this year, and it's an ongoing participation type of a plan. And so I'll let you go ahead and talk about it some more.
Okay.
Other people here on the committee?
Some of them, yes.
Okay.
Yes. Although we now have several subcommittees addressing different aspects of planning in an effort to keep meetings a little bit smaller and more focused, and hopefully keep people from having to attend either really long meetings or multiple meetings. So I've tried to to break the subcommittees out so people are mostly only serving on one, unless they've really indicated a strong desire to serve on multiple. Our forum this year and even into next year will be a virtual webinar style. And so it will be a webinar platform. It will be presented on a semi-monthly basis. We will be looking at it beginning still this fall, but moving into next year with the flexibility to continue as needed. We currently in our planning have approximately 40 session topics that we plan to have presented. And so if you quickly do the math, if we did one twice per month, one twice per month, we're looking at 20 weeks. We are looking at the possibility of 2 sessions per week for presentations. So that will potentially move us through a little bit quicker. Our planning groups have begun to prioritize which themes or session topics may be beneficial to come at the beginning of those topics. Attendees will be able to pre-register to attend live and participate in Q&A. So we will also record all of them and have them available for viewing after the live webinar. So we want to make sure that one, people have the opportunity to attend, ask questions as they have them, but also have the opportunity to watch it after the fact if they can't attend. We did recently decide that we will keep all sessions in one particular theme being live at one specific time. So as an example, the first and third Tuesday of the month, the theme of trauma will be at noon, whereas the theme of coping on the first and third Thursday of the month may be at 5 p.m. But it will be that all sessions in that particular theme will be shown at the same time. That way people have that consistency and they know. Some of the other things that we're going to do is that we're going to have calendars. And so we're going to have one overall calendar that has all sessions listed out, which also includes links to be able to register. That way people don't have to jump back and forth between pages to be able to do that, as well as calendars by theme. So if somebody has a particular interest in a topic or a range of topics and they just want to see what sessions fall within that theme, they'll be able to look at that calendar. The idea came up in our marketing meeting to do promo videos, or as some people conceptualize it as like trailers for the overall forum, for what's coming, how the format is different, as well as some of the topics. And then to do some smaller promo videos or trailers to promote specific sessions. Part of our website, we will have a page specifically dedicated to the forum. We do already actually have an events page, and right now it has nothing on it because we don't have an upcoming event. But there will be one specific page on our website, which will also be linked from the main behavioral health page too, so that people can find it pretty easily. One of the things that we've identified as a benefit of going virtual, and that it's not a one-day event and that it's ongoing, is that we have the flexibility to adapt. So if in January, let's say, we see that there are new needs needing to be addressed. We already have the platform to present this. By that point, we will have already implemented it. And we will be able to identify, we have a need for this particular type of presentation to be able to push that out. We will do a lot of social media marketing for this. We have discussed that we'll continue to do posters in the community. As people see it, we'll continue to reach out to churches either to show the video or to include a blurb either on their website or in a church bulletin. Since we know that some are meeting in person, one of the things that I would ask of you as BHCC members is that as we begin to do that, that either you personally or your agency also push out the information so that it helps reach more people.
Trish, this is Diane. I know that a network of agencies had been pushing out mental health awareness information, the Behavioral Health Action Committee, and that would be a quick and easy way, since we've already got that dissemination system set up, that we could get it pushed out through our Facebook pages. And if there would be anything that the Baby Fold could put on their electronic sign at the corner of Willow and Linden as those events get ready to be broadcast, I think we'd be happy to put an alert on there if we can just figure out what would that information be that would help people get connected.
Yeah, that would be great. And I agree about the dissemination of information through the Behavioral Health Priority Action Team. And it's actually on my mental note to bring up at our next meeting to talk about then too. So.
Thank you. Anyone else? Okay. Good report for us.
Okay. So I want to follow up on the discussion of becoming a trauma-informed county, and to recap, the intent in that is to begin to be able to measure where we as an entire county are at with regard to individuals and organizations becoming trauma-informed and implementing trauma-informed practices within their organization. And then be able to measure and identify where those organizations are at in that process of implementation. So not only being able to measure 10% of our organizations within the county are trauma-informed and implemented fully, but also we then have 10% who are at 25% of implementation. We have 15% that are at 25% implementation. So as a concept, that's what we are attempting to work toward, to be able to measure. Recently, and by recently, I mean probably about 6 weeks ago, the National Council on Behavioral Health sent out a notice to begin to receive applications about a learning collaborative to become trauma-informed organizations. And based on my reading of it, it appeared to be on an individual organization level. So I reached out to them to say, this is what we're looking at doing. Does that fit with your learning collaborative or not? And ultimately, it was intended for individual organizations and not the scope of what we're looking at. But they did send back a proposal for what we have in mind, which then also prompted me to reach out to Elizabeth Vermalia, who was our keynote from last year and who also did a breakout session on organizational implementation for trauma-informed care. And she has done some systems work and some community work on this as well. So I have had a discussion with her. One, she's willing to at least be part of a sort of discussion or brainstorming, regardless of what a role may be. But I'm waiting on more formal information back from her. All of that is to say that we are looking at the possibility of consideration of whether a consultant plays an important role in this could be useful, whether it is a financially responsible use of resources to move this forward, And after having that information back, we'll then really determine who the key players for part of the implementation collaborative would need to be, sort of separate from a bigger, more community-wide trauma collaborative. Okay.
Ready to move on?
Yep.
We are up to page 18 in your packet, Behavioral Health Coordinating Council newsletter. Great thing. I'm going to see that we get more distribution to various sources on this. Thank you for those of you who have contributed to this. I think so much good work is done in this community. Nice to get the word out and do it on a regular basis. And so thanks for doing that, Trish.
You're welcome. I do owe Judge Foley an apology for missing your name on the back of the members. So before this gets distributed to agencies to possibly disseminate or put out on social media, I will add your name and correct it. I realized that this morning.
It's already been corrected as we speak.
No worries. But thank you.
But those are also next steps, is that I will send this out as its own individual document to all of you. It will also be on social media so that it can be disseminated throughout the community. I think it's great for community members and other agencies to see what all of you are doing. It is planned that we will continue to do it on a quarterly basis. So prior to each BHCC meeting, I will reach out for any new updates from all of you. And we'll also start to reach out to some of our other community social service agencies for updates. That way it expands beyond a little bit of just BHCC members. So it will continue to move forward. And if some of those other meetings or committees that you're on have updates, when I send out the request for updates, feel free to include those as well, even if it's not your specific agency, but it's a meeting that you're up to.
Thank you. It's kind of hard to believe. I'm sorry. Can't say everyone.
Diane. I was just going to say, I think this newsletter is great, and the content and opportunity for us to be able to push it out and share it with our staff. Just thanks for doing this. I think it's excellent.
You're welcome.
Thank you. It's hard to believe it's been 5 years since we first had our initial meetings, large group meetings of all the providers in this community, involvement, and then those of you who helped us, thank you for all who's helped us to write the mental health action plan. Obviously, as part of that plan, we identified needs. Schaefer and I were on that committee and led some of the writing groups, as some of you did as well. As a counselor, counseling background, high school and college, I thought that one of the priority needs was going to be, and I wanted to address with youth and psychiatric treatment. As it turned out, we had some great groups formed, and one of them was over at the PATH office, as you remember, in crisis involvement and crisis treatment. And we've gone on from there. We've made progress along the way. One issue that's very difficult, and we've tried different ways of subcommittees to address, is the lack of practitioners. So that is still something that's an ongoing nationwide project or concern as well. We do whatever we can to supplement that, but I think the next step was that we were down to was the youth situation. We've run into some stumbling blocks on that along the way and trying to see what's the best. And I think the assessment of the needs probably changed during that time. I would like to have and I will be contacting some of you in November, a couple of roundtable sessions. And for those of you who don't know, roundtable sessions are usually held right in here. Usually they won't be able to include more than 5 people, including myself, probably because of our OMA rules. Hopefully we can have them in this size room with 5 people, maybe in person. If not, we'll see what we can do to set them up virtually. I'd like to touch base with all of you on this and see how we can move forward and get something implemented in this case. So I'll be contacting some of you to come in. Those of you who are directly involved with this, I'd like to have your input. I'd like to see where else we can go to reevaluate and see what it's going to take to move forward. I'll probably let you know who's supposed to bring the donuts, and we'll have a little session, informal session, and maybe we can regroup on this, and that would help a little. We're very proud, of course, our mental health action plan. Obviously, revisions are going to be needed in times as we move forward with this. Any organization in town that's jumped on board with us and helped us in various ways, many voluntary ways, have been very, very appreciated by me and Mrs. Schaefer and all that's been involved. So we want to continue. I made a comment once, it's probably been 4 years ago, we're not going to throw this thing on the shelf and not do something with it. And we're still driven to go ahead and help with fulfilling the needs. And you can see a number of things that have resulted from that, including this group, our health committee, our behavioral health coordinating council, Ms. Malat joining us as a supervisor. And we want to continue, and we appreciate all the support you've given us. And we're going to ask to see if we can't collaborate and move one forward and evaluate some. So that's a little bit of what I have and my goal here with this action plan. And again, I appreciate all that you've done. I want to get more input from you, and maybe it's a good time to assess again and see where we're going with it. So that's all I have on that. Do you have anything you'd like to add?
I was just going to identify that we were going to put together a project plan, sort of map out how we were going to go about it. That way we could start to provide an update, because as the chairman said, we do know that there's a possibility that some needs have changed. We have also accomplished some of what was set out in the original document. You know, 5 years is a big enough amount of time to know that we need to reevaluate. And so some of it still remains true. Again, some we've accomplished and can feel really good about that forward movement, but want to also continue to move forward as a county as well.
Thank you. We're all down to other business at this time. Does anyone have anything else to add? Ms. Schaefer, you have your hand up? Hard to see.
I did. On the youth initiative, is that what you were talking about with the roundtables? Because I just like to make a comment here that I was extremely disappointed with the lack of response from the RFP that was put out. I know COVID hit about that time, and that could have an impact on some of that. But I know that there were several of us that sat in a room and prioritized that project. And I'm really kind of disappointed that there was no response to that. And so that's just what I'd like to say about that.
All right, thank you. One other thing I'd like to say, I'd like to give credit where credit is due. It's been a few years ago since the group went to Chicago to take a look at their triage center, Cook County one. Joan Hartman's on here, isn't she someplace?
She was earlier.
I just want to say that Joan Hartman helped it, and Chestnut helped initiate that. I'm very happy that both of our accounts, our town council and city council, jumped on board with this whole mental health initiative plan that we've had, and actually that we have been able to dedicate some of our sales tax money in helping to promote this and carry it forward. We couldn't have done it without you. So the idea of intergovernmental collaborations really stands out when we have these types of projects and all that's been come to fruition from that. And I have nothing else if no one else does.
Chairman McIntyre, Diane Beattyfold, I am notoriously a glass half full person. And so Susan, I just want to provide some encouragement maybe based on your perspective about lack of response to the RFP. I think one of the good things that went on behind the scenes is a lot of hours were spent with those providers that might be seen as collaborating partners on a youth initiative, and a lot of very healthy and collegial dialogue, I think, with Tricia about looking at the needs of the community and how best we can use the resources that we have available with those tax dollars to do something that's going to be sustainable and very targeted to meet the needs. I think there still is a question about the capacity. What is the real need in terms of headcount that would utilize particular types of services, and not having accurate data about potential clients makes it very difficult to use those tax dollars in a responsible way. So I hope, you know, that maybe you and I can get a chance to talk future. We've met for coffee before so that you can really hear a lot of the details. I felt like there's a strong foundation of information shared and a good spirit of cooperation and collaboration that can be a springboard, as some folks talk with Chairman McIntyre, and keep it moving forward.
Absolutely, Diane. That's why I think we need to get together with the roundtables. But I'll be happy to come out and see you too. I know that over the years, I thought the need was to also have inpatient services. I think that's probably changed, but I'm still concerned about people and parents traveling out of town. I know that our health providers have changed some of what they've done in the past, and there's many things we need to discuss on it. So absolutely, I'd be happy to do that. I want to become involved and see what we can do to move forward with this.
Yeah.
Appreciate it. Thank you. Anyone else have anything?
Diane, I would appreciate if we could get together. So why don't you just shoot me an email?
I'll do that. Sounds good, Susan. Thanks.
Anyone else? If not, appreciate you coming. Thank you very much for your participation. And it's a great group. Stay healthy. Got somebody waving their hands. Oh,
We're just
waving
waving at each other.
Okay, we'll see you. Next meeting is Friday, December 11th. I hope we have some great things to report to you during that time. Looking forward to it. Thanks for all your participation, and this meeting is adjourned.
Thanks, everyone.